Hello. Today we are going to discuss about the fluoroscopic view of pterygopalatine fissure, which will help us to understand, to give the block of sphenopalatine ganglion. So to go inside the sphenopalatine ganglion, first I should describe the picture you can see here. So this is the skull where we can see the mandible. So this is the mandibular notch, condylar process. This is the coronoid process. This is the anterior border of the mandible. Then ramus, anterior border of the ramus. And this is your zygomatic. So somewhere here, our pterygopalatine fissure is there. Pterygopalatine fissure, which is formed in between the anterior border of the. I should take this picture. Which picture? Okay, see. Yeah, we can see here this is the pterygopalatine. We can see this teardrop shaped space. Okay, I will come in detail inside. So we can see here the coronoid notch, and this is the condylar process. This is your mandibular notch. So this coronoid notch is actually almost at the same level of the pterygopalatine fissure, through which we will enter into the pterygopalatine fossa. So pterygopalatine, pterygomaxillary, we can say also pterygomaxillary. So you can see the anterior boundary is formed by the posterior surface of the maxillary process, maxilla, and the posterior boundary is formed by the anterior border of the pterygoid plate. We can see the pterygoid plate. So this pterygoid plate and the posterior surface of the maxilla, so there is a gap between these two bones, where these two bones are united at the lower part, whereas the upper part there is an opening. So that is the teardrop shaped opening through which we have to enter, but we cannot do any end-on view here because the coronoid notch, coronoid process is there. So that's why that is not coronoid notch, this is a coronoid process, and this is the mandibular notch. So coronoid process is obstructing because it is almost at the end-on view level of the pterygopalatine fossa. So that's why we are entering through the coronoid, we are entering through the mandibular notch. We are taking the needle as anterior as possible of the mandibular notch, so that we will be almost parallel to enter into the pterygopalatine fossa. In many books, it is written that you hit the pterygoid plate and then you take the needle anterior and superior. What I feel, because this is a sharp border, so many times you may get stuck there. So better to touch the posterior surface of the, posterior surface of the maxilla and slip into the pterygopalatine fossa. So that's why if you understand the pterygopalatine fissure, if you understand the pterygomaxillary fissure in the fluoroscopic view, in the X-ray view, then you don't have to think about opposite vas, which is usually we are taught about also opposite vas. You should definitely know that how the opposite vas is formed, because X-ray view never shows you the depth. So many structures are there at the same level, but that they are in the different depth that we see in a two-dimensional X-ray view. That's why we need to see the other view to understand the depth. So we can see here only the direction. So we will take the needle as anterior as possible at the mandibular notch, and we'll hit the posterior surface of the maxilla and enter into the. So if we see the other, just for anatomy knowledge, we can see here the this is the posterior view. We can see here this is the posterior nasal aperture, this is the vomer and the palatine bone, and this is the both the side the pterygoid process. This is the medial pterygoid plate, lateral pterygoid plate. So from the lateral pterygoid plate, outside and inside, the muscles which are pterygoid, lateral pterygoid and medial pterygoid, and medial pterygoid plate that is forming the pharynx. So I'm not going to that. So lateral pterygoid plate, if you see from posteriorly, so you have to think your needle should not go posterior. If your needle is going posterior, you are keep on going inside, so then you are in danger. You may pierce so many complicated structures there. Your needle may go into the pharynx. It may hit the common carotid artery, internal iliac artery, internal carotid artery. Okay, so needle should not go posterior. Keep it in your mind. So if you see any lateral view picture, so here one through this notch, when you are entering, needle should not go posterior. Needle should be always, don't take the needle too much inside and come back. So you should not do these things, because unless you know the real anatomy of the head face, so you should not try these procedures so that where you don't know the real anatomy, where you are going the wrong place. Okay, so you can see here how through the foramen oval, the mandibular nerve is coming down. So once you hit the pterygoid plate, just withdraw a little bit, you can stimulate, you will get the twitch of the masseter or another muscle supplied by the by the mandibular nerve. In that way you can find out, but unless you entering into the pterygopalatine fossa through this pterygomaxillary fissure, you cannot access the maxillary nerve. We can see here, I will come in detail about the maxillary nerve. See, here you can see this is the body of the sphenoid, and this small foramen, it is actually pterygoid canal. Pterygoid canal is starting from the foramen lacerum. You can see here the internal carotid artery, how this part is cut actually. So this is the foramen lacerum, through which the internal carotid artery with the greater petrosal and the deep petrosal nerve, they are forming the median nerve, and that is the preganglionic of the preganglionic sympathetic parasympathetic of, because deep petrosal is the preganglionic postganglionic sympathetic, and greater petrosal nerve is the preganglionic parasympathetic. I will come to that part a little bit, because we should know before going to the procedure, we should know, because this is such a small area posterior to the maxilla and anterior to the pterygoid plate, medial to the at the lateral border of the nose, at the upper part of the palatine level. So this is the small hole. We can see here this is a pterygoid canal through which the preganglionic sympathetic parasympathetic is coming and joining, the forming the median nerve, and this is a parasympathetic ganglion. Why it is called parasympathetic ganglion? Because the parasympathetic relay happens, whereas sympathetic relay doesn't happen. Sympathetic just pass through this. Okay, and all postganglionic fibers of the parasympathetic are taken help by the branches of maxillary nerve. So all these 5 branches, when we see the cluster headache, all these symptoms from the this lacrimal gland to the palate, pharynx, everywhere supply is coming from there, from the postganglionic fibers, which these preganglionic fibers, they are coming from the facial nerve, preganglionic parasympathetic. So that is from there, preganglionic fibers are coming, and postganglionic, this facial, this is taking help of the maxillary nerve at the postganglionic fibers. Okay, so now we can see the small upper this nerve. There's a maxillary nerve which is coming through the foramen rotundum. We can see here the this trigeminal ganglion is dividing into upper, middle, and lower. The V1, V2, V3. V1 going through the supraorbital fissure, V2 going through the foramen rotundum, and V3 going through the foramen oval. And just beside that, beside the foramen oval, you will see the foramen lacerum, through which through the pterygoid canal in the foramen lacerum, this autonomic fibers are coming and forming this sphenopalatine ganglion. So now we have to enter here. Now coming to the okay, I will give you little anatomic part of this, what I was telling here now. See how the maxillary nerve is coming from the trigeminal ganglion. This upper part is the V1, this is V2, and this is V3. V3 is coming down, so here you will get the foramen oval. So this is going through the foramen rotundum. Then in the maxilla, see, this is giving all this superior, middle superior, anterior superior, posterior superior, all these alveolar branches. That's why we have seen for lower jaw, we can block with one infraalveolar nerve, all the teeth the dentists are doing, but for the upper level, they have to separately block. Now coming to the, so we can see here how the infraorbital fissure, and behind this, we are getting this two foramen, in between these two foramen, infraorbital fissure and foramen rotundum, the space is coming, that is the pterygopalatine fossa, where we can see this black pterygopalatine ganglion is hanging. This is the preganglionic postganglionic fibers. Now coming to the autonomic, if you see here, the superior cerebral nucleus, from where this facial nerve, from the facial nerve, geniculate ganglion, there the preganglionic fibers are coming, that is the greater protosal nerve, and we can see the sympathetic fibers from the T1 up to the superior cervical ganglion. So from there, postganglionic fibers. So postganglionic fibers are not there in the postganglionic, sympathetic fibers are not there in the sphenopalatine ganglion. So we can see here relay is happening here only for the parasympathetic. All the branches are actually the branches of maxillary. So that is supporting this postganglionic fibers of the pterygopalatine ganglion. Okay. So this pharyngeal branch, the palatine branch, nasal branch, lacrimal branch, that's how you are getting symptoms here in the pterygopalatine headache or cluster headache. Okay, and here the preganglionic fibers, superior sympathetic ganglion, from their postganglionic fibers taking the help of the internal carotid artery that is going through the foramen lacerum, and it is passing through the sphenopalatine ganglion and supplying the same areas. So when you are blocking, when you are targeting the sphenopalatine ganglion, we are targeting sympathetic, but actually it is a parasympathetic ganglion. So we are targeting sympathetic. So that's why we can block here also. In the same symptom, we can block in the stellate also. That is the anatomical correlation. Why the same effect we are getting, we may get by blocking the stellate as well as same at the pterygopalatine ganglion, because the sympathetic fibers are arising from this postganglionic sympathetic fibers are arising from this stellate ganglion, but in the pterygopalatine ganglion, the postganglion fibers are passing through this. They are not relaying. That's why the ganglion name is parasympathetic ganglion, not sympathetic ganglion, whereas sympathetic ganglions are closer to the spinal cord, closer to the thoracic region. Okay, closer to the vertebral column, whatever you say. So now coming to the our lateral view, because this procedure is started with the lateral view, then finalized with the AP view. So if you see the lateral picture, see for example, I am showing you this picture. So this is the picture you can see in the lateral view. You have to try to superimpose all the structures like your mandible, like your maxilla, your pterygoid plate, everything you have to superimpose, because then only we can superimpose both the side pterygopalatine fissure. There is teardrop shaped pterygopalatine fissure. So if you see my hand here in the marker, like, so we used to see where is the opposite vase. Same picture I will take, say like this. So here you can see, so this light blue, that is the one part of the opposite vase, and the light blue here in the posterior surface of the maxilla, that is another part of the opposite vase. Okay, so this we are taught in the book, but I, in studying anatomy, what I felt, if we try to figure out the pterygopalatine fissure itself, then my direction, my target will be direct into the foramen. I don't have to find out the opposite vase and hit the pterygoid plate, then enter into the, I never do that. What I do, first, after superimposing all the structures, then first you see the posterior surface of the maxilla. You can see here posterior surface of the maxilla, posterior surface of the maxilla. So that is the first target, because I have to hit this and I will slide inside. You can see this red color teardrop shaped, that is the pterygopalatine fissure. We can see actually this pterygoid plate is a very thin plate. So that's why in X-ray you may not differentiate, may not find out the posterior border of the pterygoid plate. It is impossible because they're very thin plate. Just like when you see the vertebra, the transverse process is very thin. It is not the calcium is low or the bone density is low. They are the thin plate. That's why you may not see the boundary or the border of this bone. So you can imagine this here. So that's why your needle cannot go posterior. You cannot take the needle posterior too much inside because you will be in danger. So first you have to see, once you superimpose both the mandibles, you have to find out where is the mandibular notch. I can show you another picture. Yeah, here you can see it is on the other side. So here you can see this green is the coronoid process. This is the mandibular notch. Okay, and this red is the posterior border of the pterygoid plate. Here again you can see the teardrop shaped pterygopalatine fissure. So this anterior surface of the posterior surface of the maxilla, and the inferior border of the zygomatic and the greater wing of the sphenoid. So they are forming the opposite vas. Okay, so what I told in X-ray, when we see the X-ray in two-dimensional view, we don't know the depth of so many structures there. If you just simply, you see the depth of the coronoid process and the depth of the pterygoid plate, they are not same. So depth of the zygomatic and depth of the, this you can see here cella turcica, they are not same, but it is looking like same. Why? Because it cannot show you the depth. For that we have to see the epiview, then we can finalize the position. So that is the drawback of the X-ray. We cannot see the depth. You can find out only the, you can target only your direction. Here we can see the white dot. We can see the white dot. That is, I am taking the first I am finding out the lower border, this mandibular notch. Then I am imagining this coronoid process because that is almost at the same level of the pterygopalatine fissure, and I am taking my entry point as anterior as possible in this notch, so that I will be, because this is the process, this is the procedure where you have to, you cannot do it in end-on view. You have to do it out of the end-on view, out of the plane kind of. So there, I will take the needle as anterior as possible or just posterior to the coronoid process, so that my needle will be almost parallel to enter into the pterygopalatine fissure. So this is the very, very important thing. So now I think everything is very much clear to you. Again, you see this picture. You can see again this picture, how this coronoid, this skeletal anatomy will correlate with the fluoroanatomy, where you see the zygomatic is cut here. So the posterior, the lower part of the zygomatic and the inferior surface of the sphenoid, greater wing of the sphenoid. And on the other side, the posterior surface of the maxilla, they are forming the opposite vas. But even if you don't find out the opposite vas, you try to focus the pterygopalatine fissure. You take any X-ray here, see, you try to find out the notch. You just see the zygomatic process. So below this zygomatic process, in between this zygomatic and the mandibular notch, just anterior part, you will get this teardrop shaped pterygopalatine fissure. I think this will help you to find out the pterygopalatine fissure. And once you enter little bit, immediately you come to the epiview, so that in epiview you can come to the posterior border of the nose, but below the orbit. Keep it in your mind, your needle may go up through the infraorbital fissure, so that should not be there. So even if you see your needle is little going upwards, your needle is bent needle, so you can direct the needle so that in such a way that needle will be coming superior, needle will come medial, not too much superior, so needle will come anterior. So these are the directions how ultimately you will reach at the lateral border of the nose, and then your stimulation will be started. So I think this will help you with all these pictures. Again, you can see This is the posterior surface of the maxilla. This is the anterior border of the pterygoid plate. Okay, so this we can see the pterygoid hammer. This is the posterior border of the pterygoid plate. So this is the teardrop shaped pterygopattern fissure, which is joined inferior part, but it is open in the superior part. Through this, we are actually entering into the pterygopattern fossa.